Ganguly sir?
आवाज नहीं आ रही।
Yes, are
Yes, sir.
हाँ,
no sound.
आवाज नहीं आ
no
रही।
sound, ma'am.
आवाज नहीं आ रही।
Yeah, ma'am, there is no sound.
Shared, but sound नहीं जा रहा है. I don't know what is the problem.
साउंड ऑन करो ना, उसमें जाके ऑप्शन में जाके।
सर किया है, नहीं हो रहा है.
आपका कंप्यूटर का साउंड
Sir,
देखो।
sir, we are live. Sir, we are live.
चलो
Ma'am, we
ठीक
are live. Okay.
Shall we start?
भेज
Yeah,
दें।
ma'am, we are live. Kindly start.
Yeah, ma'am, please start.
Yeah, good evening. Today is the World AIDS Day. A constant research, revised treatment has overcome fatality in this disease. Similarly, when we learn, relearn, and unlearn, we go ahead in science and to give something excellent to the humanity. In our academic journey for last 4 years, we have tried to provide the recent advances and excellent review articles thanks to Dr. Mohanty sir and the research papers given in MGM for our pediatric fraternity. We welcome all the dignitaries for this last episode of 2025. I am very happy to have office bearers here, and for that, a formal welcome is needed, which is given by our star member of Raigad IIP, editor Dr. Neha Singh. Over to you, Dr. Neha.
Good evening to all the respected dignitaries, my seniors, colleagues. I, Dr. Neha Singh, on behalf of MahaIP and Raigad IIP, I welcome all to all of you today on 1st of December, the last journal journey reading for this year 2025, and reciting the famous lines of John Kennedy. The goal of education is the advancement of knowledge and the dissemination of truth. I welcome MahaIP President Dr. Sanjay Pakmore sir, State Convener Dr. Sanjay Deshmukh sir, MahaIP President 2022 Dr. Hemant Gangulia sir, MahaIP Treasurer Dr. Ravindra Sonavne sir, Scientific Convener Dr. Meenakshi sir, Raigad IIP President Dr. Vikas More sir, Secretary Dr. Ajay Kohli, respected Dr. Neeman Mohanty sir, Dr. Chitra Kulkarni ma'am, and all the respected executive board members from the Central IIP,
डॉक्टर रमाकांत पाटिल,
Raigad IIP, as well as
मेरा नाम रमाकांत पाटिल, डॉक्टर
Yes.
रमाकांत।
I also welcome MahaIP President 2023, Dr. Ramakant Patil sir. Welcome, sir. I also welcome our esteemed experts of today, Dr. Nikhil Pawar and Dr. Anand Edkar sir, and our presenters of today, Dr. Pratiksha Nehete and Dr. Nisha Zogte. So now I invite MahaIP President Dr. Sanjay Pakmore sir to please give his blessings. Over to you, sir.
Thank you, Neha. Now, today is the last episode of means journal journey will definitely continue, but the last episode in 2025 tenure means I think the words will not be enough to express my gratitude personally from my side and from the MahaIP for the Raigad branch and Chitra madam, Neha, and of course Vikas and Dr. Kohli and the people who started the journey really like the respected Dr. Hemant Gangulia sir, Jay Bhandarkar sir, and all the Raigad branch MahaIPLs. Now, means this is such a beginning. Means every president starts on the day one with the journal journey. His journey starts and the journal journey starts at the same time, and this day always coincide with so many days like Doctor's Day in the middle of the year and so many days, but still it is means the journal journey means is very means every month it is done on the very first day of every month, which gives a boost to any academic activity in that particular month. So lots of efforts are put behind the behind, especially I must thank Dr. Niman Mohanty sir, who has started this particular journal journey, and his experience helps in selecting the topics as well as selecting the presenters and the experts. And his help is done by Dr. Chitra madam and Neha and Vikas and so many people. So first of all, let me thank all of you for all the 12 months, the way journal journey took place. It was really a wonderful thing because it helps everyone to revisit the medical colleges. I mean, this gives a typical feeling of we are again in the medical college, and the way the topics are chosen, they are the current topics, and which really help because in these days, lot means we are busy in our OPDs, and still after the journal journey, we definitely get a feeling ki we are by that discussion from the experts and the presenters and the people like Niman Mohanty sir, we get some insight into the newer topics so that it helps in updating our practice as well as indirectly helping the society. So the beginners means the one people who started and the journey is continuous in the last 4 years, and it will be continued in future for so many years. And from my side, I'm really thankful to Raigad IIP. Rather, this journal journey will never be means it will not happen. It will be, even though I'm not on the post, it will definitely means I can be present as a attendee for that journal journey, and no doubt on the first I will always remember the journal journey. And once again, I congratulate the people who have started this particular journal journey. Really, it was an innovative idea to start this particular thing. Means so many scientific programs we see, and but this is means what I have observed in my 25 to 30 years of practice. This type of scientific activity is really a very different thing which has been started, and hence it is continued since last 4 years, and hope in the future it will again gain its means it will reach to the newer heights because the persons behind this journal journey are so dedicated, and for this activity so much rehearsal is done. I mean, and for any activity to have some but before the activity so many things are going and then it is presented, that's the beauty of this particular activity. So I really congratulate Raigad IIP branch and hope you continue with every president, whoever is coming in future, so that, and I think there will be always from president also, there will not be anything. He will not say he will not continue journal journey because he's getting a ready-made activity, one scientific activity at the very first day of his tenure, at the same time every month, the very first day of the every month. So I, with the folded hands, I really means thank you all of you for continuing this journal journey in 2025 without fail. And Chitra madam and Neha, you are the pillar of this journal journey. And of course, since 2-3 years, Dr. Vikas and Dr. Kohli, they are continuing as a president and secretary, and definitely the advisors like Hemant Gangulia sir, Jay Bandhandkar sir, Chandrasekhar Dabadkar sir, and all the names I can take.
Our
And
mentor,
today,
Dr. Mohanty sir is also there.
Niman Mohanty sir, I said in them only, he's a Janak. He's a Janak of this particular activity. He's pioneer of this particular activity. Today, I must welcome all the people who have joined for the today's journal journey. 3 presidents are already, including me, 3 are already there. Dr. R.D. sir, 2023. Hemant Gangulia sir, past presidents of MAHA-IP. So out of 4, 3 are already there. so we can see everybody journey, and all the MahaIP office bearers and the CIP office bearers who have joined for this particular activity. At the same time, the today's experts and today's presenters. Uh, I wish you all the best, and let's learn from our presenters as well as the experts and their beautiful, conversation, our interaction between them, and let's get updated to this particular two topics. So thank you once again from the bottom of my heart.
Thank you so much, sir. And we will be very glad if you join us in future also. And we are very blessed to have you, and that you have given us your MahaIP platform. And through all the year round, you have always encouraged and blessed us. Thank you so much, sir. So I invite MahaIP President 2022, Dr. Hemant Gangulia, sir, to say a few words and give his blessings. Over to you, sir.
Thank you very much, Dr. Neha, and good evening and namaste to all respected dignitaries of MahaIP and respected dignitaries of the IIP Raigad, as well as the presenters, the experts, as well as our mentor, Dr. Nimen Mohanty, sir. Dr. Sanjay, sir, we do understand your emotions, and you have expressed all the emotions. I think so. This scientific episode is lucky one to each of the MahaIP president. And I think so. The live example is there. कि RD sir has also joined of 2023. और मुझे लगता है ये फेविकोल का जोड़ है, छूटेगा नहीं जल्दी से. तो सब लोग हम लोग जुड़ते जा रहे हैं जर्नल जर्नी से. आई एम वेरी एक्सट्रीमली हैप्पी. आई एम वेरी मच हैप्पी. This journal journey thing, idea and everything started on the Doctor's Day itself in the year 2021. And then it was the myself and Dr. Jay Bhandarkar with, of course, with the mentor, our Dr. Mohanty sir, Dr. Chitra Kulkarni madam, and then the presidents, Dr. Sunita Ingle and the secretary, Dr. Nilima Bhandarkar of IIP Raigad. We started on the Doctor's Day of 2021. And then it continued when I became the president, MahaIP president year 2022. And I'm very much we are very extremely thankful to all incoming MahaIP president, namely Dr. Ramakant Patil sir in 2023, then Dr. Ram Gopal Sejara in 2024, and then Dr. Sanjay Pakmode sir in 2025. All these have continued, and so this is journey of almost 4.5 years. And all episode, I think so, only 1 or 2 episodes must have been shifted or postponed to the other dates. Otherwise, was always on the first of every month. And yes, Dr. Sanjay Pakmode sir has stated every MahaIP president starts with this journal journey episode. I think so it is a booster for his activities for the year. And I think so, and whoever the president comes for the next year, 2026, hope so he will continue, and we will be continuing this thing if they agree with us and to give this platform from the MahaIP. Very innovative idea. Everything is going ahead. And of course, as said by Dr. Sanjay Pakmode, this reminds of the Medical Colleges Day. And therefore, this is the crux and the idea of Dr. Mohanty sir also. So I'm very, very much happy for 4.5 years journey, and I think so journey will continue. And I all the best wishes to the today's presenters, as well as all the best wishes. I know the experts are very esteemed experts are there. Dr. Anand Ritkar and Dr. I think so Nikhil is there. Nikhil is there, the expert. So both are there. So they are esteemed experts from this. And in a hearty congratulations to Dr. Ravindra Sonawne also, because he's the EB of MahaIP 2000, EB of CIP from Maharashtra State in 2026. So he will be also there with us, and I would like to say welcome also. I will take, because the last episode, this is the last episode of this year, but not last episode of Journal Journey. So it will continue. So I will just also would like to take the names of Dr. Sanjay Deshmukh sir. Thank you, sir, convener. Dr. Ramakant Patil sir, 2023 president. Thank you very much, sir. For that, Dr. Mohanty sir also. And the last but not the least, the most important person, Pallavi Dharmadhikari. She did wonderful work from since 2022, where we are associated with her, and every time she does wonderful work, and she's continuing, she's giving, contributing very much to the MAHA-IP. Thank you, Doctor. I can call you Dr. Pallavi if you are there. So thank you very much for that. And with that, I wish my all the best and thank you very much.
I miss Pallavi,
Thank
madam, your name also. I also means thankful to you for the whole years your support.
Thank you, sir. Now I invite Dr. Rabindra Sunamne, sir, and then Dr. Sanjay Deshmukh, sir, to say a few words of blessings. Over to you, sir. both of you.
I
Thank
forgot
you.
Dr. Sagar Bhalero is also there. Thank you, Dr.
Yes.
Sagar Bhalero, for joining it.
Thank you, Neha, madam. Good evening, respected seniors, dear colleagues, and beloved members of the MAHA-IP and Raigad IIP fraternity. We often say, when you stumble, make it part of the dance. In academics and in life, every misstep teaches us a new step forward, and every new learning becomes part of our shared journey towards the excellence. Today's journal journey is exactly that celebration of learning, reflections and प्रोग्रेशन. ऍक्च्युली म्हणजे ह्या वर्षाचा शेवटचा एपिसोड आहे, पण असं म्हणायला काही हरकत नहीं कि अभी ये जर्नी बाकी है, अभी भी इसको डेस्टिनेशन मिलना बाकी है और जर्नी कंटिन्यू रहेगी. एज अ ट्रेजर ऑफ MAHA-IP gives me a great pleasure to welcome. I am truly grateful to see such an enthusiastic participation from across the state. Together, we continue to uphold the ethos of continuous medical education and evidence-based pediatric practice. This evening, we are privileged to have two distinguished experts with us, Dr. Nikhil Pawar from Nasik, pediatric neurologist, Vidya Vikas, working at Vidya Vikas Child Neuro Clinic, and Dr. Anand Litkar, senior pediatrician from Kalyan. And our presenters today being compelling and clinically relevant topics. Dr. Pratiksha Ajit Nehte, she is my colleague. She is working as a SR at Dr. Vasundhara Power Medical College, Nasik. And second, Dr. Nisha Zorpe, she is practicing pediatrician from Kalambori. And my sincere appreciation to our moderators, Dr. Chitra Kulkarni, Chairperson elect MAHA-IP Raigarh, and Dr. Neha Singh, Editor and Joint Secretary IIP Raigarh, and backbone of this all journal journey, Dr. Mohanty sir. And heartfelt thanks to our leadership teams, Dr. Sanjay Pakmode sir, President MAHA-IP 2025, Sanjay Deshmukh sir, our convener, then scientific convener Dr. Minaj Sheikh, then Dr. Hemant Gangolia sir, Dr. Ramakant Patil sir, Dr. Jay Bhandarkar sir, and my friend Raigad President Dr. Vikas More, and Secretary Dr. Ajay Kohli, and entire MAHA-IP and IIP Raigad team for their constant encouragement. And also Dr. Sagar Bhalero, welcome. Thank you all for joining us through Zoom and YouTube Live. Let us engage and learn and take away insights that will shape better outcomes for the children we care for. With this, I warmly welcome to all journey. Let the learning begins. Thank you, Neha.
Thank you so much, sir. Sanjay, sir.
Yes, good evening, respected MAHA-IP office bearers and Central IP office bearers. The words are very less to express our gratitude to the IIP Raigarh branch. Gangulia sir has given the history and this journey will be never end. तर आपण म्हणतो ना, जेव्हा आपण प्रवासाला जातो तर काही काही प्रवास असे असतात की आपण विचार करतो की हा प्रवास थांबला नाही पाहिजे. आणि जनरल जर्नी इज वन ऑफ द ॲक्टिव्हिटी which is very dear to the MAHA-IP. And we are thankful to the IIP Raigarh. They are every year they are doing fantastic work, bringing so many young talent to the MAHA-IP platform. And this is only possible due to combined efforts of MAHA-IP and IIP Raigarh. So we are indebted to the IIP Raigarh, all peoples, Neha, Gangulia sir, Dr. Vikas, Dr. Ajay, our MAHA-IP president, Dr. Pakmode, Minaj Bhai, all MAHA-IP office bearers. We are coming to the end of this MAHA-IP journey, but rightly said by all people, next year, 1st January, we will again meet with the smiling faces of IIP Raigad with a discussion on the general journey. So my best wishes and thank you very much.
Thank you so much, sir. Now I invite our Raigad IP President, Dr. Vikas More, sir. Over to you, sir.
And with new IIP Raigad office bearer as well as IIP office bearers. Yes, Dr. Vikas.
Yes.
Yeah. Thank you so much, Neha, for giving the opportunity. First of all, I offer my obeisances to all my seniors, our able President, Dr. Sanjay Pakmode sir, for his blessing throughout the year. And ably, I know the respected Gangulia sir, respected Ramakant Patil sir, Dr. Ramakant Chezara sir, he is not there in absentia because I am so fortunate to work under three presidents, Dr. Ramakant Patil sir, then Ram Gopal Chezara sir, and now Pakmode sir. So this is the last month of my presidency of IIP Raigad. So next month you are going to get a very exciting new team. Which is going to do a much better work than our team. So we have not announced yet, but it is a pleasant surprise for all of you. Now, for me, this journal journey is very close to my heart because it is a activities um, uh, like devised by the good brains of our IP Raigad and now has been accepted by the blessing from all the seniors from all our MAIP and also CIIP. So I'm so much proud of that, and I'm so much proud of my team, Dr. Chitra Kulkarni Madam and Dr. Neha Singh and our respected Mohanty sir. So we are so fortunate to have the brains like Mohit sir, Gangulia sir, Dr. Jay Bhandakar sir, Dabadkar sir, who constantly encourage us to do new things and new innovative things. That's why IP Raigad is able to maintain its flagship position in state level and national level. Being a president, it is my people say that how can do so much work at a time because I can do this work just because of my team. All credit goes to my team, and I'm ably assisted by my own friend Dr. Ajay Kori. A special word to all today's presenters, Dr. Pratiksha from Nashik and Dr. our new generation, Dr. Nisha Dhodpe from Kalamboli. Dr. Nikhil Pawar as an expert, and Thomas, thank you for being joining as an expert. And Dr. Anand Itkar, sir, special word for sir, because I admire his work. Sir, many people might not be knowing the kind of work he is doing in Kalyan. We are now talking regarding the paperless work these days, but sir is having like every discharge card of his every neonate since last 30 years in his mobile at any moment. So if you ask any patient record, it is available on his phone. So that kind of expertise sir is having. So sir is doing extraordinary work in Kalyan. I request all people to visit his setup and especially read his discharge card. Then you will understand the kind of work he is doing. And with this, because the time is already, we are touching 9:25, so I'm not going to take much time. Special respect to Dr. Sanjay Deshmukh sir and Minash Sheikh sir and my friend Ravindra Surane. We are having two top vote gainers, Dr. Ramakant Patil and Dr. Ravindra Surane, who win by highest margin in Maharashtra. Very congratulations for you. And many people have joined today. I will not take much names because I'm eating more time. So today's time is now for academics. So let's directly go to the academics right now. Over to you, Neha. Thank you so much.
Sir, please introduce our experts. Dr. Vikas, please introduce our experts.
Yeah. So now this Dr. Nikhil Pawar sir, has done his fellowship in pediatric neurology from BJ Wadia. Now he's a founder director of Vidya Vikas Child Neuro Clinic in Nashik. He's visiting consultant at Saifalya and Chiranjeevi and Kims Hospital in Nashik. So he has a 10 plus years of pediatric neurology experience. Thank you so much for joining as an expert, Dr. Nikhil. And then Dr. Anand Itkar sir, as I told you, he's a senior pediatrician and neurologist from Kalyan. He has more than 30 years of experience in neonatology. He's a level 3 NSU, well equipped, with therapeutic hypothermia and cerebral functional monitoring. So he has an excellent setup in Kalyan. Everybody is requested to visit this setup if you are interested in starting a level 3 setup. Dr. Pratiksha, who is working as an SR in Vasantrao Naik, this thing at along with Sononi sir, and she has done her MBBS from Sri Vasantrao Naik GMC Yavatmal, done her DCH from Punjab Rao Deshmukh Medical College Amravati, and done her DNB from Fortis Hospital, Mulund, Mumbai. Thank you so much for being a presenter today. Dr. Nisha Satai Zodpe, she is our Gen Z of IIP Raigad. She is a new blood of IIP Raigad, upcoming new leadership. So she has done her MBBS from IGMC Nagpur, done a DCH from Terna Medical College, Navi Mumbai. Started her practice at Siddhartha Child Clinic at Road Pali, Kalamboli. Very enthusiastic and always take a lead role in all various activities of IIP Raigad. Thank you so much, all of you, for being a presenter and expert on the behalf of IIP Raigad. Thank you. Over to you. Yeah.
Yes, sir. Thank you so much, sir. Now I invite Dr. Pratiksha to please share her slides. Dr. Pratiksha, are you there?
Yes,
Is she
ma'am.
comfortable?
Please share my PPT, ma'am.
Pallavi ma'am is sharing, no? Yeah.
No, I am sharing.
Neha. Thank you very much, Dr. Neha.
Yes, Dr. Pratiksha, you can start.
Yes. Thank you so much, sir and ma'am, for the introduction. Good evening, everyone. I begin with my presentation. Today, my topic for the journal journey is leukopenia in children on anti-seizure medication is common and has a minor clinical impact, which was published in the renowned Journal of Pediatric with the impact factor of 4.4, and this was published in the volume 282 in the July 2025. As we know, leukopenia is a known adverse effect of anti-seizure medications, historically believed to be rare, but nowadays newer real-world data suggest higher prevalence of leukopenia in the patient with anti-seizure medication. Basically, the mechanism proposed was still unclear, but it is thought to be it is associated with immune-mediated reactions, apoptosis acceleration, and bone marrow suppression. The aims and objectives of the studies were to determine the prevalence of leukopenia in children receiving anti-seizure medications, identify the anti-seizure medication specific and patient-specific risk factor, and assess the clinical impact regarding the infections, hematologic complications, and treatment modification. This was the retrospective cohort study. It was performed in the Astrid Lindgren Children's Hospital, Sweden. It included 198 pediatric epilepsy patients, which were less than 18 years of age and which were on anti-seizure medications. The data extracted was from the electronic medical record, which includes the blood counts, clinical events, and anti-seizure medication history. This study defined leukopenia as absolute leukocyte count less than the lower limit of normal, and they categorize it as a mild, which is with absolute leukocyte count is 3 into 10 to the power 9 cells per liter, moderate between 2 to 3 cells into 10 to the power 9 cells per liter, severe is between 1 to 2, and life-threatening is less than 1 into 10 to the power 9 cells per liter. The statistical analysis here was logistic regression, ROC curve, Mann-Whitney U test, and Fisher exact test. Next, ma'am. The result actually out of 198 patients, the 97 patients were associated with leukopenia, which was nearly 49%, in which 88% of episodes were mild, which when there was no any life-threatening incidents with leukopenia. Older age group, multi-organ dysfunction, longer anti-seizure medication duration, combination therapy, all were associated with higher incidence of leukopenia. Anti-seizure medication, lower leukopenia is associated with levetiracetam, brivaracetam, topiramate, zonisamide, corticosteroids. The anti-seizure medication with higher incidence of leukopenia is found in stiripentol, carbamazepine, and valproate. In the patient with leukopenia, it was found that the 62% of the patient were associated with other cytopenia like thrombocytopenia. The clinical symptoms of the leukopenia were also found, but these were rare in the form of paronychia, mild mucosal lesions, which were less than 1%. Next. As we see, this table showed the leukopenia is associated with a slightly older age group, which is nearly 11 years of age. And also the incidence of leukopenia is found in the patient with other organ dysfunctions like heart disease, endocrine disease, kidney dysfunctions, etc. While the other parameters like sex, ethnicity, pregnancy, prematurity related complications, epilepsy causes, these were equally present in both leukopenia and non-leukopenia patient group. Next. This table showed the leukopenia is found in both the older as well as newer generation of anti-seizure medication. It was also found that the deeper leukopenia is found with the patient on the ketogenic diet. Next. Also, this table showed in the patient with leukopenia, they had done the two they switched the anti-seizure medications. Also, they taper the anti-seizure medication in patient with leukopenia. In that, they found that there was minimal impact on the WBC count, even if they switched the anti-seizure medication or taper the anti-seizure medication. Also, they did not influence on the seizures in this patient. And the symptoms of the leukopenia in the form of aphthous stomatitis, gingivitis, paronychia, these were also rare, out of which paronychia was found in 2% of the patient. Next. Conclusion, leukopenia is more common in children on anti-seizure medications than previously recognized. Previously, it was 0.06%. Nowadays, it was found to be 5.6%. It was leukopenia is mostly mild and clinically insignificant. Routine discontinuation or switching of anti-seizure medication is not required for the mild leukopenia. Only the monitoring is adequate. Treatment should prioritize seizure control. The limitations of the studies were it was a retrospective design with inconsistent lab frequency across the patient, also the inconsistent follow-up. It was predominantly European study and limited availability of full differential count in all the episodes. The potential underestimation of asymptomatic episodes. My take on the topic is anti-seizure medication associated leukopenia is common but usually benign, reinforces need for the periodic CBC monitoring, especially in the polytherapy and long-term therapy. Clinical decision should balance the seizure control and minimal hematological risk. It is useful data for counseling the parents and guiding follow protocol in pediatric epilepsy clinic. Next. What need future clarification, as more studies are needed on the mechanism behind the anti-seizure medication induced leukopenia, why it is found in some patient and why it is not found in the other patient on anti-seizure medication. Thank you.
Thank you, Dr. Pratiksha, for a very nice presentation. Now I want to invite Dr. Am I audible?
Yes.
Yeah, I invite Dr. Nikhil Pawar, sir, for his expertise comments. Over to you, sir.
Good evening, everyone. Very well presented. So what we see here is this is a journal which this is an article published in the Journal of Pediatrics, which is a well-respected, indexed and peer-reviewed pediatric journal. The other thing is it's a single center and retrospective cohort, which is actually presents a good real-world scenario, but it is not the final word. Neither this article helps in practice changing guideline. It does not set up any guideline for changing the practice. So though it's a good quality article, it's still a single center retrospective study, and I see it as a hypothesis generating data, and it's not a guideline by itself. And what this article had shown that leukopenia was anyway common. 50% of the children had at least one episode. Most of these episodes were mild, like around 80 to 90% were often transient episodes. And only one had severe neutropenia, and none of them had any life-threatening leukopenias. And even if the anti-seizure medications were changed or tapered, it was only for 4% of the episodes. Seizure control and OPD visits were not affected. So, and what I feel is the message from this article is the leukopenia in kids who are on anti-seizure medications are common, and it is just biochemically we can see the same interesting trend here, but it is clinically not significant. And the other thing which I would like to emphasize is if we can compare the strengths and limitation of this study or this article. So the strength, I would say that there was a reasonable size, like 198 patient of pediatric cohort, that was good. And then it also had a real world mix of patients. Like few patients were on multiple anti-seizure medicines. Some of them were having comorbidities. So this is how our real world like clinics look like. And they just did not stop at the lab values. They looked at the seizures, the visits, and admissions. So those were the strength of this study. But what I felt was that this is just a single Swedish territory tertiary center. For Indian setting, this genetics, the infection profile, nutrition profile will definitely vary. And where this is where we cannot apply this study findings. And being retrospective again, that is another drawback. It has its own confounding factors, which might be with the help of because of the infections and other drugs. The third point which I found is they have selected most recent 198 patients. So this could be an overrepresentation of more complicated or heavily treated patients. So it wasn't randomized. It was like just the last 198 patients which they had seen. They should have taken it over a period of time, I would say. And again, it was not powered enough to give that any drug specific risk profile. Like it did not mention that which medicine, which anti-seizure medicine caused the most or the severe leukopenia. So it was only mentioned. I mean, this study only showed us that leukopenia was seen in almost all the ASMs. So I would again conclude that we can see more leukopenia, and it's almost mild. And just copying their CBC schedule that every 3 months to be done, it should not be blindly taken into the Indian practice. And the last most important question is, should I start doing CBCs for all my epilepsy patients? Well, no, I will not do for all, but definitely this paper gives one thing that we have to do a targeted monitoring for high risk patients. Like if the child is on polytherapy, more than 2 or 3 anti-epileptics, or if the child has organ system diseases, malnutrition, recurrent infections, I need to be a little careful here and need to do some CBC monitoring in these patients at least. So the to conclude, I would say uh, this is a very good study showing almost half of the children have on ASMs developing leukopenia. But for my practice, I will keep this baseline CBCs and focus monitoring only in the high risk children. And I will not overreact to this mild leukopenia. Uh, Over to you, ma'am.
Thank you, sir. Very good review.
You're welcome.
Now I request we will take the questions at the end of second presentation and the expert comments. Now I request our second presenter, Raigad IIP member, Dr. Nisha Satai, to start her presentation. Dr. Neha, can you share?
Dr. Nisha, are you going to share or I have to?
I will just try.
Dr. Neha, you can share.
Okay.
Whatever is comfortable for you.
Neha, you can start sharing. Good evening to all my seniors, respected seniors and friends. Uh, previous one. Myself, Dr. Nisha Satai. I am presenting today article from Pediatric Clinic of North America PCNA, which was published in year 2025 with impact factor of 1.9. Today's topic is identifying infants at risk of mild hypoxic ischemic encephalopathy, and we are going to discuss about three things: mild HIE, risk stratification, and therapeutic hypothermia. Next. Yeah. HIE is the leading cause of neonatal brain injury, morbidity, and mortality. In highly resources setting, incidence is 1.7 to 2.96 per thousand live births. But in less resources setting, incidence is as high as 11.7 to 13 per thousand live births. But it has been found that therapeutic hypothermia leads to reduced mortality and neurodevelopmental disability in cohort of patients of moderate and severe HIE, but evidence of applying TH in mild HIE is lacking. Next. Emerging evidence suggests that babies, even with mild HIE, can experience developmental language, attention, and behavioral issues later in life. That's why diagnosis of even mild HIE is important. It should be identified ideally within 6 hours after birth. To assess, we use modified Cernat score. 6 criteria are used: level of consciousness, spontaneous activity, posture, tone and primitive reflexes, and autonomic nervous system dysfunction. If more than 3 are present, it is categorized as moderate to severe HIE, and if seizures are present, then it is categorized as severe HIE. If less than 3 are present, then it is mild HIE. Next. Then, why does diagnosing mild HIE matter? Because meta-analysis shows that 25% of babies with mild HIE also show abnormal outcome. Worst outcome could be death or cerebral palsy also. By 5 years of age, 35% of kids shows lower IQ, lower verbal and performance IQ. There is one study, PRIME study, which is prospective research in infants with mild HIE. It shows that out of 54 infants who didn't receive therapeutic hypothermia, 43 came for follow up. Out of these 43, 16% had disabilities. The disabilities constitute 2% had cerebral palsy, 5% had autism, then 40% had were scoring less on developmental scale. In The impairment was in the form of language impairment, cognitive impairment, and motor impairment. These findings highlight the fact that there is subset of patients with mild HIE who remain at risk of adverse outcomes. There are a few clinical biomarkers also which help us, like evidence of perinatal distress, resuscitation required at birth, then cord blood pH analysis if it is less than 7 or base deficit more than 16, then Apgar score less than 5 in 10 minutes. Next is physical examination and total Cernat score, which we already seen. In study of 11 neonates, it was found that 7 progressed to moderate HIE with time. Abnormal tone within 6 hours is highly sensitive criteria. Then one more supporting investigation is EEG. As a large proportion of neonatal seizures remain electrographic, clinicians often use continuous video EEG or amplitude EEG to assess degree of encephalopathy. Next. There is one criteria: intact survival rate. It means it is defined as baby is free from all types of disabilities at 5 years of age. It was found that if EEG was abnormal at 6 hours, this survival rate was only 75% as compared to normal, which is 97%. If EEG was abnormal at 24 hours, the survival rate was 65% as compared to normal, which was 94%. Next. Then one more investigation, important investigation, is MRI. HIE injury can be evaluated within first week of life by MRI. Cohort study of 52 infants shows that 34% of mild HIE babies shows injury of both white matter and basal ganglia. Then there is one study by Walsh which shows that 54% babies of HIE have abnormal MRI results. Additionally, watershed injury was similar across all grades of HIE, but while basal ganglia and thalamic injury was more frequently observed in severe HIE. Next. But there is therapeutic drift. Then how misuse of therapeutic hypothermia in mild HIE. It should be used or not used. There is one Canadian study. It is for applicable for developed countries. 215 infants were selected, out of which 79 were mild HIE. 13 received TH. They had less brain injury as compared to 50 babies who were normothermic. They had higher MRI injury. But there are few shortcomings in use of therapeutic hypothermia. TH increases hospital stay, it increases duration of respiratory support, opioid use, then there is risk of coagulopathy, thrombocytopenia, persistent metabolic acidosis. TH can cause hepatic and cardiac dysfunction also. And baby is more likely to be discharged with home oxygen and tube feeding. These are the shortcomings in using therapeutic hypothermia. Then there is one important HELIX trial, which is conducted for low income and middle income countries. This trial shows that for moderate and severe HIE, combined outcome at 18 months was similar between hypothermic and control groups. That is 50% and 47%, which is almost similar. So this study, which is for low income countries, it shows that TH should not be used for HIE treatment in low income and middle income regions, raising concerns about its universal application. Then, in summary, we get few points like mild HIE is also associated with potential long-term neurodevelopmental sequelae, so these babies should not be missed. Then check for evidence of asphyxia at birth. Detailed neurologic examination is important. Then risk stratify babies according to Sarnat score. Then ABG and EEG, these investigations can help us. Then TH should be offered in high income and well equipped centers. And follow up with developmental pediatrician is important. Next slide. Then I have added one note on therapeutic hypothermia. What is therapeutic hypothermia? It involves cooling newborn baby's core temperature between 33 to 34 degrees to reduce brain injury. This should typically start within 6 hours and gradually rewarming should be done for after 72 hours. How it works? It works by reducing brain metabolic rate, decreasing cerebral metabolism and slowing down cell death process that occur after HIE. In short, it halts the process and it halts progression. So how it is given? There is passive cooling. We remove the socks and caps. Then active cooling by giving cooling blankets and socks. Then for 72 hours followed by rewarming. But continuous monitoring of vitals is required during that period and such setup is required. So there is a diagrammatic representation of therapeutic hypothermia, how it works, and what is our take on this article. More Indian studies are required to support use of TH in mild HIE, but as Western countries are already using, we can use it for moderate and severe HIE. At present, it is difficult, but in future it might be useful if setup and affordability allows. Then risk stratifying babies is important, and follow up with developmental pediatrician is must for mild HIE babies also. Thank you, Raigad IIP, for giving me opportunity to present this topic today.
Thank you, Dr. Nisha, for such a nice presentation in your first attempt. And we are really very, very fortunate to have an expert today who is actually practicing like this. Over to you, Dr. Anant Itkar.
Thank you, ma'am. I wish to share something, so please allow me to share.
Yes, please, sir. Pallavi ma'am? Yeah, thank you, sir.
Yeah, माझ्या स्लाइड्स दिसतायत आता?
Yes, sir.
Yeah. I am Dr. Itkar. I am practicing pediatrician and mainly in the field of neonatology at Kalyan. I am using therapeutic hypothermia and cerebral function monitoring, that is amplitude EEG, from last several years, maybe more than 7, 8 years. And I have seen this, how it is useful.
Sir,
Huh?
yeah. Again, we can see your slides. Yeah.
So, a very important thing in all this is how to differentiate between mild HIE and moderate to severe HIE. Because all our dilemma is to use whether to use for a mild or not. It is proven everywhere that all the standard guidelines are there for using moderate to severe HIE. So what are right now guidelines for using for HIE is that there should be baby should be at least 1.8 to 2 kg. Some centers say the 1.8 kg, some centers 2 kg. Another around 36 weeks. But we get so many babies who are preterm and they are not eligible or they are not in coming in that criteria, but they need a therapeutic hypothermia. And babies below 1.8 kgs also, there are significant number of chunk of babies who are having asphyxia at a lower weight. So both of these babies are devoid of therapeutic hypothermia. Third is there has to be a history of birth asphyxia and followed by encephalopathy. So encephalopathy is decided by modified Sernat criteria and mainly by 5 clinical parameters. And this has to be seen within first 6 hours. See, in practicality, in our setups in India, all where, by the time those babies reach to us, it's sometimes more than 6 hours. Sometimes they reach within 1 hour, 2 hours, but sometimes it may go prolonged. So at present, right now, guidelines are before 6 hours, but there are some centers worldwide who are using therapeutic hypothermia up to 12 hours. But for defining mild HIE, we are dependent on 5 clinical parameters which are dynamic, which change over hours. So if these are not static, at 1 hour, if there is a HIE, there is no mild HIE, but within few hours, baby may develop in mild HIE. So it's difficult to say at one point of time. See, when the Sernat and Sernat criteria initially was developed, that time those babies were followed up over weeks and then decided whether this is a mild, moderate or severe. But here, what is happening that at one point of time, we have to decide whether this is a mild or moderate or severe. So we need to have some newer criteria to decide about or some number-wise, numerical data where we can say this is a mild, moderate and severe. It's very difficult to say from modified Sernat and Sernat criteria to whether this is a mild and moderate. Second thing, what are the data coming from PCNA that they are saying that there is so many morbidities, which we feel it's really difficult to digest that much percentage of morbidities. So in clinical practice, what we are doing routinely, if baby is coming and if baby's pH is below 7, and we get a pH below 7 so many times, and we use amplitude EEG routinely. Amplitude EEG is a very, very sensitive. Before giving a seizure, clinical seizure or motor seizures, we get a electrical seizures, and it's a very easy to use. See, classical conventional EEG is difficult to use for a neonatology people or a routine pediatricians. But amplitude EEG, which anybody can read with a span of 2 to 3 hours of learning. It's that easy technique, and it's even our sisters right now read those. So we decide mainly with a pH and amplitude EEG. So in our setup, subclinical seizures are obviously seen on a amplitude EEG. And third thing is practicality. In our setups, we cannot do a MRI within first 6 hours. There is definitely a limitation in Indian setups that we cannot do a MRI in first 26 hours. But we can definitely get a ABG, base excess, and amplitude EEG. At least in my setup, amplitude EEG may not be available in every setup, but in my setup we have amplitude EEG. So it's a very easy to think. Third thing is what is the current evidence right now for a therapeutic hypothermia is for a moderate to severe. There are some center off-label offering for a milder hypothermia, milder cases. So in conclusion, we need to define the criteria for HIE. Mild HIE should undergo a therapeutic hypothermia. That's what my feeling is. And we need to have several prospective studies for mild therapeutic hypothermia. We cannot go on using off-label treatment in a larger perspective. So coming back to a critical, this is a machine which we are using routinely. This is a critical machine, which is a servo control. One important thing about the hypothermia is that it should be servo controlled. So what is servo control means? We have one thermometer positioned in a rectum, and that manages the temperature of the body, and there is a wrap around a baby. See here in this diagram, we are able to see these are the pipes which go to the wrap, and there is a one rectal thermometer in a baby's rectum, which automatically or servo controlled manages the temperature of a baby. We have seen several babies that on admission or when we start a therapeutic hypothermia, amplitude EEG is a very poor. Their lower margins are below 5 microvolt. And as we complete at 72 hours, and when their slow rewarming starts, that time their EEG has improved. It has normalized. Sleep-awake pattern has appeared, and there are no seizures. So there is a dramatic change while using a therapeutic hypothermia. And as a gut feeling or as I feel a clinician, this should be extended to the milder because right now we are using this therapeutic hypothermia maybe once in 2 months or so. But if I am using this for a milder criteria or milder HIE, I may be able to use it maybe once in a week because milder babies are much higher in numbers and they are devoid of this such a novel treatment. But there need to be several prospective study and it has to come as a standard treatment guidelines. At present, standard treatment guidelines are baby should be at least 2 kg, 36 weeks of gestation. There has to be history of asphyxia. There should be some sentinel event happen. And then there has to be signs of a HIE, maybe in the form of modified Sennett staging. Then ABG should have a pH below 7 or base excess should be more than -16 or there should be clinically evident seizures. These are the criteria right now for using a therapeutic hypothermia. There is a need to have several studies in this field. Thank you so much. And one more thing that for a therapeutic hypothermia, lot of damage happened basically related to the HELIX study. Ma'am was saying about the HELIX study. HELIX study is having several pitfalls in their conducting. So I have noted down some pitfalls is that there are cooling started several times after 6 hours in HELIX study. This study was mainly conducted in India, Bangladesh and Sri Lanka. And several our centers where baby has not reached before 6 hours. Then second thing, very few of these centers were equipped with amplitude EEG. Then sepsis was a very important part of a deciding in these cases. These were not a classically only a HIE babies, and sepsis contributed a lot of mortality. And 1 minute. And the protocols in all the centers were not uniform. There was a heterogeneity in protocol management. And so I feel 3 years back, this study came, 3.5 years back. And this has made a lot of damage in percolating this therapeutic hypothermia in India, because after that, several doctors were hesitant to purchase these machines. But now it has now proven again that even in Indian setups, even in a resource limited settings, therapeutic hypothermia works, and it is a standard of care. Thank you so much.
Thank you. Thank you so much, sir. And now we are having another expert with us from Raigad IIP, Dr. Mahesh Mohite, sir. Your comments on this article, sir. Dr. Mahesh Mohite, sir.
One more comment I wish to have
Yes,
in
yes,
that
sir. Yes, sir.
several people are using cooling blankets without servo control, and that causes a lot of fluctuation in the core temperature, and it is more harmful. So if we have to use a therapeutic hypothermia, we should use servo controlled machines rather than just using cool blankets.
Yeah.
It's available and it can be done.
Yeah. Over to Dr. Mahesh Mohite, sir, for his comments, expert comments, sir.
Hi, Anand. How are you?
Hi.
Good to see you after a long time.
Yeah.
And Dr. Monty sir is there, and all my friends are there. Actually, this is a topic which I have been discussing even since the time we started practicing 35 years ago. And things have changed. Obviously, when we started, then cooling was just about to be discussed, not even started. And then came from the Western world that this is something which is a life changer and all those things. But it was practically started in our scenario about 2.5 to 3, about 2 or 2.5 decades, say 20, 25 years ago. And when they had the interim analysis within first 5 to 10 years, in fact, they said there is no mortality benefit, there is no morbidity benefit. And at one point of time, when Western world was thinking of discarding it totally. But then came the long-term follow-up of 2 decades, 15 to 20 years, and they said, yes, there is a huge advantage of it, especially in moderate to severe. So far the evidence even by Cochrane database is only for moderate to severe. There is no evidence in the mild variety at all. That defining this HI as mild to moderate again is a very billion-dollar question. As Anand said, it's less than 7 pH. But there is a category which is 7 to 7.15 pH, which can be taken as mild provided you have got a Apgar scoring of less than 5. And that's what he said, that's a clinical setting. So once your baby not cried and Apgar less than 5, on that base, if we have a pH 7.15 and a BiCARB less than 15, then straight away this baby qualifies. And many of our babies qualify for this setting, which need to be taken as moderate and zero. So like Anand said, 7 pH if you take Anand, then I agree that it may once in 2 months. But we follow less than 7.15 with a Apgar of less than 5 and a BiCARB of 15. And then believe me, we are doing about say 2 coolings every month. And we are using Miracredal. We are using Miracredal, and we are very happy doing that. I don't use amplitude integrated EEG. Our protocol is between 12 to 24 hours, we do one standard EEG. And we do get the baseline encephalopathy plus seizure. And of course, we are monitoring for the clinical seizures. It will be interesting to compare your data with our data, outcome data. And perhaps because you need to understand, it is a cost demanding as well. The whole setup that we are using with the full cap and the AED, I mean the amplitude integrated, that cost you almost 25 lakh rupees today. And a Miracredal is a simple device. Now at times we have 2, 3, 4 babies of HI. We can afford to buy that many Miracredals. But having full cap of 2 or 3, it's very difficult. So which one to prioritize and which one not? And again, as you said, low income, middle income, I think it's a very complex scenario. So I'm quite happy the way we are doing. And I totally agree. Mild, honestly, categorized by Sarnat scoring. Mild is just a jittery baby with a doubtful HI. Baby didn't cry, required maybe very, very minimal resuscitation, and then mentally be slightly irritable and jittery, but tone well maintained, rather on a higher side, and within 24 hours, child doing well. And this is a baby who start feeding within 12 to 24 hours. And those are the babies, if you start putting them on a cooling, then cooling demands at 72 hours of sedation and followed by all those things. So probably we'll be overdoing. That's what is my guess in that. So we restrict it to moderate on a clinical grounds of Sarnat with a pH that level less than 7.15. And by moderate, I mean to say, here's a baby who's definitely encephalopathic, had a seizure, tone being still preserved. And in case of severe, it will be tone loss and almost many times seizure with or without seizure. It has gone beyond the seizure. It's already encephalopathic to a tune that he don't have even clinical seizure. He is already hypotonic. And in fact, tone becomes an extremely important pickup as well as a prognosticatory marker. Some baby is not regaining tone by 24 hours. I know it's going to be bad prognostically. So I think following that, this will be a good idea. Now, some word about HI, about the MRI. In a clinical scenario, in Indian scenario, doing MRI perhaps comes after 3 days of cooling. If this baby is not recovering at the end of 3 days, I would come done with the cooling. This baby is stuck to the ventilator. By now, moderate to severe, most of them they'll end up with ventilation because one of the drawback of cooling, sometimes they go into apnea. And if that is not picked up and it develops another event of hypoxia at that time, you are really putting oil in the fire and you are going to damage. So we have very low threshold for putting these patients on ventilator. If this baby is put on ventilator, you are done with 3 days of cooling and you are weaning off and child is still not looking active at all. Obviously, we use morphine for only first 24 hours, then we wean it off, we stop it after that. So this is the time on day 4, if this baby is still not regaining his sensorium, is not regaining a tone adequately, then MRI is to decide whether I have to continue or I have to give them a bad prognostication and let them take a call. Because at this point on day 4, day 5, I see those severe diffusion restrictions in the basal ganglia and that area. I know the outcome is going to be extremely bad, and that's reasonably kind of evidence base. And then, so if at all MRI stands there, MRI doesn't really help you or within first 6 to 12 hours. And none of the ischemic kind of a brain injuries, one would recommend to do prognostication MRI within first 3 days. You go for all evidences, there it's not recommended. Usually it's recommended after 48 hours. So that's about it. And I had written something more. Fine. I think that's all. Multiple reports. Again, cooling after 6 hours, up to 24 hours. There were a few kind of calls, a few kind of a recommendation. You can do up to 24 hours. But again, later you do after 6 hours, so 12 hours, 18 hours, the outcome is not as comparable as something which is done within 6 hours. Unfortunately, coming from the cell, like you are in Kalyan, you get the baby from Kalyan, it will reach within 6 hours. But if it's referred from Murbad or some other place where the obstetrician has delivered and you receive it after 6 to 8 hours, you have lost that huge window of opportunity. And same thing in Raigad area. In Panvel or Niabra area, we get that. But if ladies coming from Mahad or Alibag or Mandgaon or something, I mean, there are so many difficulties in transporting this child. Many times you have to pick up the baby, going up there and coming back. So you already gone beyond 6 to 12 hours. And then the traveling, I mean, those are the limitations we have. So the units with the in-house obstetrics, perhaps this is appropriately applicable. Most of our pediatrician unit, which are not inborn, most of them are outborn. I think half the babies lose that brilliant window of opportunity to apply cooling in the right time. And those are the limitations of this kind of a device. Mild HI, I think we need lot of evidence here to put it, recommend it, because that is going to be a huge additional financial burden also. Don't forget that. Once you put on a cooling 3 days, whatever requirements are huge. So we need to be very careful before recommending it to the mild. In the Western world, where everything is taken care of by the government and public system, it's okay. In Indian scenario, this is something which is huge demanding. Suddenly you will require to buy 3-4 cooling blankets, which is, and then if you don't have it, like you said, at the end, you will be facing a medical legal. Why didn't you cool my baby? And that will be really a dangerous scenario. So I think we need really a good, huge evidence to recommend it to the mild one in an Indian scenario. That's all from my side. Thank you very much.
One more thing that so many of mild HI, we label them as a parental depression and we pass on. We don't admit also. probably. There are so
Absolutely.
many babies who are coming, to whom we see in obstetric setups, and we just consider they are like a perinatal depression, just don't admit, or they are never followed up. This is one thing. Second thing, I feel this is very important to differentiate between chronic intrauterine hypoxia and acute hypoxia at the time of intrapartum hypoxia. This is very useful tool for intrapartum hypoxia, not for the chronic intrauterine hypoxia. So we need to differentiate between these two conditions. Probably Helix trial was involved with several babies who were a chronic intrauterine hypoxia.
Yeah. Sir, Mohite sir, any other comment, like for how many years you are doing it in your setup?
Almost now more than 10 years.
Yeah.
But we are using Miracredin.
Okay.
Not to forget few of the limitations. You have got a baby. Many of these babies were asphyxiated. They have got myocardial dysfunction. They have got pulmonary hypertension. So they may be having shock. So those are the babies who need to be immediately stopped, because giving the whole body cooling to this baby will be counterproductive on this underlying comorbidity. So in fact, out of 10, maybe 3 are withdrawn from cooling because one of those things. Do you agree with me, Anand? Those are the babies where we will not be able to put it.
We use occasionally inotropes in these cases.
No, we do, but I said refractory, something which is really requiring 2 inotropes or something. Then
No,
definitely
no,
will not
we
be
have
able to
not come across with that situation. But one thing I should have brought a amplitude EEG's tracing at this time, that before starting therapeutic hypothermia and at the time of completing therapeutic hypothermia, there is a radical change. And if we all see that in a EEG, everybody will think about using therapeutic hypothermia. It's that magical. But that is definitely for a moderate to severe. I have never used with a mild cases.
So it is a very good discussion that whether to do it for mild or not. And Dr. Mohanty sir, your take on why you have selected this article?
Thank you, Dr. Chitra. Actually, the first article, although it is going against our expectation line. So in research, always you should not expect that anticipate the expected line. This article shows that if a negative result is also a research and it should be taken seriously, so that similar studies may not be necessary in the future. So this is cost intensive efforts should be taken care of. Then a lot of inputs have gone to presenter during our discussion, in-house discussion. She has done a very good work. I have nothing to add there. Here about the therapeutic hypothermia, we also started using therapeutic hypothermia here and Aurangabad, MGM Aurangabad. So cost intensive is definitely yes. And addition of MRI to it has increased the cost. So in the Western data, if they are using a different modality of investigation, including MRI, and the cost is not comparable to our setup. We should not get scared of using this, hesitate using this for the cost. And in selective basis, we should use, particularly mild ones, we should try selectively use whenever it's seriously indicated. And my comment, my suggestion rather, to both our experts, excellent work done. The way they have presented, I thought two pleaders are standing in the court, and very effective results both of them have pointed out. I would suggest, please combine your data, both of you, and publish it as compared to the similar data in PGI Chandigarh, neurology, pediatric neurology, or AIMS. Let's have a pooled data, and we can definitely have a way ahead for our country. Thank you.
Thank you.
Yeah, thank you. Thank you, sir. I could see past MahaIP President Dr. Ramakant Patil, sir, very good academician. Sir, your comments? Dr. Ramakant Patil?
Hello, good
Yes, sir.
evening.
Good evening, sir.
My comment, because I do not have personal experience about this therapeutic hypothermia, so it will be just a review of literature. I do not have further to add what Dr. Litkar and Dr. Mahesh has already told us. That there is helix trial, and this we should be really wary, because multi-centric further data is required, as Dr. Litkar has said about the helix trial. So the selection of the patient and documentation is very important. And what important point he has made, it is about the intrauterine, not the chronic hypoxia, but it is a intrapartum hypoxia which is most likely to get benefited. And about the leukopenia, I do agree with Dr. Nikhil Pawar that it is really, we very rarely get a granulocytosis or leukopenia which is really severe, and there are definitely no guidelines when we should really work up this patient or monitor this patient for leukopenias or like that, but it should be at our back of our mind. Thank you.
Yeah, thank you, sir. Sir, our next journal journey will be in 2026, and the two new topics which were selected are, first is review article and predictors of risk of cerebral palsy, and this is selected by our mentor Dr. Mohanty sir. The second article is new CPR guidelines, and it is aiming to save more lives. It is very recent, published on 30th October 2025.
This is a
Pallavi
wonderful
ma'am,
document.
yeah.
This is a
Pallavi
wonderful
ma'am,
document. Absolutely.
any questions in YouTube? Can you see?
Chitra ma'am, I just add one sentence here. The first review article you have suggested, which is on a cerebral palsy, it is from a sister branch, that is physiotherapy. And the study was conducted by ICMR funding, and it's a very good study. I thought it should come to the pediatricians also to give a feedback. But whenever the cerebral palsy comes, there is a tendency from our side, including me, we refer this to physiotherapy only and forget it. So let's see what physiotherapy people think about it. And this is a very good senior people are to this work, and it is really a PhD work done by the first author.
Good to
Monty
know.
sir, about the second study of CPR, I think this is extremely important to discuss more, because the whole trend and concept is changing towards blood pressure monitoring, which is diastolic blood pressure in pediatric. We never thought the major important landmark change in our concept of monitoring diastolic pressure post CPR. So that's very important. There are 2-3 major changes, but what I found is diastolic blood pressure focused, which is absolutely new to us. And believe me, most of the critical care conferences will be discussing henceforth diastolic blood pressure. So it's very important. That article is really very good. I'm going to attend it definitely.
Published in the last month only.
Yes.
I read all 4 documents. It is for pediatric and adult CPR both, and post CPR management. So they are extremely wonderful written documents.
Yeah.
Thank you.
Medscape. Yeah. Any comments from other dignitaries? Dr. Ravindra sir?
Ma'am, there is no question on YouTube.
Okay. Okay.
हो मॅडम.
Thank you.
त्यांनी एवढं छान सांगितलं थेरपेटिक हायपोथर्मिया. तर आता आम्ही विचार करतोय वसंतराव पवार मेडिकल कॉलेजला. मी सरांना फोन करतो, मोहिते सरांना उद्या विचारतो, त्याच्याबद्दल थोडी माहिती घेतो. थँक्यू सर.
Yeah, President sir.
Yes, it was a wonderful presentation from both Pratiksha and Nisha, and wonderful comments from all the experts, Dr. Nikhil, Dr. Anand sir, and Dr. Mahesh Mohite sir. And really it added something new in our knowledge, because we also I also not also experienced in hypothermia. So lot of insights from the today's topics and lot to be learned. And once again, I wish all the best for the new journey from 1st Jan 2026. And I thank Raigad IIP and all the office bearers and moderators, especially Chitra Madam Neha and patron like Hemant Gangolia sir and Jay Bhandarkar sir, Chandrasekhar Dabadkar sir, and everybody from MahaIP platform for this particular journal journey from and of course the mentor Niman Mohanty sir for the continuous 12 activities in 2025, coinciding with the so many days, and really never to be forgotten in the future, and will attend in future as not as an office bearer, but as a definitely a
As
common
an
Maha
expert. As an expert, sir.
You can, madam.
Sir,
Anytime you need it, I will be there. Yes, sir.
President sir, I only request you, when we see that there is no question, we feel probably we are not taking our audience along with us. Please tell them and encourage them to ask us questions to generate more discussion.
Surely, sir. Your
Thank you.
inputs will be taken forwards, and I will definitely pass your inputs to the incoming president and the office bearers, so that means there will be a wonderful interaction again with the
Yeah,
audience who are
it will
attending.
encourage the
Yes,
presenters.
definitely it will encourage
Young
the host.
presenters, you can see their performance.
Yes, sir. Definitely, sir.
Yeah, now since there are no questions, we have to go for Thanksgiving. I'm extremely thankful and grateful for continuous cooperation of MahaIP President Dr. Sanjay Pakmode sir, Secretary as well as Treasurer, and Dr. Ravindra Sonane sir. Then the best part of this journal journey that we got an expert like Dr. Anant Itkar sir with help of Dr. Hemant Gangolia, where we could learn the intricacies of this therapy. And wonderful presentation by both presenters, Dr. Nisha Satai as well as Dr. Pratiksha Nehete, and the expert Dr. Young Dynamic Dr. Nikhil Pawar, who has given critical appraisal for this topic, which we could have taken it granted that yes, we have to do CBCs of all these patients who come to general pediatrician, but no, it is not needed. And that is the carry home message which we got with this discussion. Thank you so much, Dr. Nikhil Pawar, for that. And I could see 26 to 27 login here plus YouTube. That means our journal journey is definitely very, very popular. Thank you and wishing you all Happy New Year in advance. Yes, Dr. Hemant Gangolia, sir.
So thanks lot, MahaIP, for giving us company this year, and I'm looking forward to meet you in the next episodes too. And all the best wishes for their endeavors in 2026, Dr. Mahesh Mohiti sir with the new post, Dr. Ramakant Patil sir, as well as Dr. Ravindra Sonane as in CIPEB for 2026 representing Maharashtra, and hope so. They all the best wishes for their work in CIP. And also Dr. Vikas, you have done wonderful job for last 3 years, as well as Dr. Ajay Kohli. And these two people, they are also probably ending up their tenure in this month, and they will be a pleasant surprise who will be the next office bearers to us. And let us hope the new year, Happy New Year 2026, coming with new office bearers of both MahaIP as well as IIP Raigad. And we will be giving new dimensions to these episodes of Journal Journey, and we hope it will continue and it will be have a extraordinary look also. And last but not the least, I think so we should clap for Dr. Chitra Madam as well as Dr. Neha Singh to take all the efforts. It requires all the efforts. I know what pain it is and how and all those guided by our mentor, Dr. Nimen Monti sir. He's so much out of the Mumbai in Orissa. He phones me, Hemant में नहीं है वो एपिसोड में देख ले क्या करना है. तो ये सो काइंड आई डोंट नो. मैंने सर आप ज्वाइन तो करना 10 मिनट के लिए, कोई प्रॉब्लम नहीं है, बाद में फिर आप चले जाना. एंड
I joined from the train.
Yes.
I joined this
Yes.
episode.
Yes. Yeah.
That is a commitment from sir.
So that time I was at EMLACon to Orissa, and sir came to meet me also there, and whole day he was with us for that conference of the Medical Legal Conference, National Conference. So kind of you, sir, Mohanty sir, and I am really amazed with the presentation with Dr. Nisha also presented. It was her first attempt, and she did wonderful job. And also Dr. Pratiksha madam and experts they are experts. I will not commend them. They are extreme comments. My namaskar to them and my hats off to them. All those, and of course the experts, Dr. Anand Itkar. I know him for so many years, and Dr. Mohitesh sir. And what Vikas sir said, the discharge summary of Dr. Anand Itkar should be seen. Means I am saying with the perspective of medical legal. So perfect discharge, you will not realize. It's a very perfect. Most of the times in my talks also, when I always say, I remember one neonatologist discharge notes, and it should be that way. And Dr. Anand Itkar, you should teach.
Thank you, sir. Thank you so much.
And
Sir, it should be shown to.
He will say कि the patient coming from Dr. Gangolia from Neral at this time came to my hospital this time in this condition. What Dr. Gangolia did also he will mention what he did, and then he will write the things. So wonderful written. So it gets a query follow-up. And what Dr. Mahesh Mohanty sir, I am not aware of so much what is the technology, but whatever you do, there's only one take. Whatever you do, please document the things, and whether you should go or not. I think so we are so much afraid of these things. We should not get afraid. What you're doing, it should be as the standard protocol, standard things, and whether things we are deviating from the standard lines, you should mention the reason for deviating the lines. That is an important tagline for that. When you deviate, you write what is the reasons, and what are the reasons that could be justified in the court of law. So nothing to be get afraid. The technologies are going to come. There will be pros and cons. Everything is shared. Everything we cannot should go in the sale. And both people, Dr. Mahesh Mohanty sir and Dr. Anand Itkar, they are doing a good job. I appreciate them. And मेरा साष्टांग नमस्कार है आप दोनों के लिए. And thank you very much for that. Thank you.
Thank you, sir. Thank you so much for kind words.
Thank you, Pallavi Dharmadhikari ma'am.
Your discharge card,
Pallavi
please send me a copy.
Yes, you
Yes,
should
sir.
show. It should be shown to all the people because we also love to see it, sir, and learn something from it.
We wanted to teach our PGs.
Yes.
How
I
to
will directly send to you, sir.
Okay, thank you.
Mohit sir, thank you so much for joining. He was not there.
Okay.
For
Shall we
everyone,
stop the recording now?
Yeah.
Pallavi
Yeah.
ma'am? Thank you
Mohit
very
sir.
much, Pallavi Dharmadhikari ma'am.
Thank you, Chitra madam.